Welcome back to the Best PT Podcast. This is episode 5.1, Wounds, the first episode of the integumentary system. The skin is the largest organ of the body with dermal and epidermal layers, hair follicles, nails, sebaceous glands, and sweat glands. Remember that the epidermis is avascular, the most superficial layer of skin, and that the dermis is our true skin. It is well vascularized, flexible, and tough. Some basics about wound healing. The inflammatory phase lasts 1 to 10 days after a wound. This involves platelet activation and the clotting cascade. Mast cells, neutrophils, leukocytes all kill bacteria and remove dead tissue. The main goal here is the preparation of a clean wound bed that signals permanent repair processes. Re-epithelialization occurs within 24 hours at the wound borders. Proliferation phase occurs 3 to 21 days after a wound. Capillary buds and granulation fill the wound bed. The migration of epithelial cells occurs, and wound closure occurs through epithelialization and wound contraction. And finally, the maturation phase lasts from 7 days to 2 years. Granulation tissue and epithelial differentiation occurs in the wound bed. The scar shrinks and thins. An immature scar will be red, raised, and rigid. A mature scar will be pale, flat, and pliable. Freshly repaired wounds have 15% of their pre-injury integrity, increasing over time to 80%. Burns are the slowest healing of all wounds, 4 to 8 weeks for a non-hypertrophic burn, and 8 weeks to 2 years for a hypertrophic burn. Different types of healing intentions. Primary intention occurs in acute wounds with minimal tissue loss. Smooth, clean wound edges are approximated with sutures, staples, or adhesives. Superficial partial thickness wounds like abrasions or blisters also heal through primary intention. Epithelial migration occurs within 72 hours, and wounds heal quickly with minimal or no scarring. Secondary intention. Wounds close on their own without superficial closure. Wounds with significant tissue loss, necrosis, irregular or non-viable wound margins cannot be approximated through sutures, staples, or adhesives. Closure occurs by wound contraction and formation of scars. These wounds require ongoing wound care. These result in larger scars. These are often caused by neuropathic, arterial, venous, and pressure ulcers. These are full-thickness wounds. Finally, tertiary intention is delayed primary intention healing. These are wounds at risk for sepsis that may be left open on purpose to treat risk factors before applying primary intention methods. Wounds with edema, debris contamination, and poorly vascularized wounds often heal through tertiary intention. Factors that affect wound healing include age. As we age, the epidermis thins and flattens with age, which makes it more fragile, more susceptible to injury, and with a slower metabolism comes slower wound healing. Comorbidities. The two largest comorbidities that affect wound healing are smoking and diabetes, resulting in poor tissue perfusion of blood. Edema. Excessive edema can affect tissue perfusion and prevent removal of cellular debris and result in reduced oxygen availability. Harsh and inappropriate wound care. So aggressive wound irrigation, debridement, whirlpool exposure, or overuse of cleaning agents can result in damage to peripheral and granulating tissues, slowing or preventing wound healing. Infections overwhelm our natural immune response. Bacteria can also release toxins and steal nutrients that reduces or reverses the healing process. Lifestyle, regular physical activity, and good nutrition increase tissue perfusion of oxygen and nutrients. Medication, anti-inflammatory medication, and anticoagulants will slow the wound healing process. With obesity, the skin is susceptible to fissuring due to increased skin tension. That's it for episode 5.1, talking about wounds. The next episode, 5.2, will talk about classifying and staging wounds. As always, the outline will be in the show notes. Thanks for joining me.